NEI Spring Congress is headed to my home of Florida, May 1st through 3rd, and I hope you'll join me. Come for the latest in psychopharmacology. Stay connected with like-minded clinicians and experts. Walk away with the tools that make a real difference in clinical care. Registration is open now, and spots are filling fast. Use code NEIPOD26. That's all capitalized, NEIPOD26. Register now at nei.global/spring.
Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and chief medical officer of NEI, Dr. Andrew Cutler, sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. I'm Dr. Andy Cutler, and with me today is a friend, Dr. Holly Swartz, who is a world authority, a world expert in bipolar disorder and mood disorders, and she's at the University of Pittsburgh. Holly, how are you?
Hi, thanks so much for having me. I'm really glad to be here.
Absolutely. Well, what we're going to be talking about is not just medication for bipolar disorder. We're going to talk about the fact that, Holly, I conceptualize bipolar disorder as more than just mood dysregulation. It's also dysregulation of motivation, reward, but also arousal, circadian rhythm, and sleep. And I hope we can talk a little bit about that.
Yeah, absolutely. You know, I am a psychiatrist, and I am, of course, somebody who believes in and prescribes medication for bipolar disorder all the time. But I also am a real advocate for the importance of behavioral interventions. And, you know, the complex pathways implicated in bipolar disorder demand a complex set of interventions. And so I think I'm really excited today to talk about some of these multilateral approaches that we need to take to optimize health.
Yeah, I really like that conceptualization. You know, sometimes I use the analogy of diabetes. If we were treating diabetes, you wouldn't just give someone insulin and say, eat all the chocolate cake you want and don't diet and exercise and, all that. So, of course, it's a combination of many things. Well, let's focus in on sleep in particular. Why is sleep regulation so central to mood stability and bipolar? And is sleep disturbance, and Holly, I actually got asked this last night at a dinner talk, is sleep disturbance a symptom, a trigger, or both?
Sleep is incredibly important in bipolar disorder for lots of different reasons. And I think, you know, as you just sort of foreshadowed, it's both a symptom, dysregulation of sleep is both a symptom of the disorder, and dysregulated sleep is a trigger for mood episodes. And so it's really a potent set of symptoms, if you will, that we need to track in individuals living with bipolar disorder because it tells us sort of where we are in the bipolar illness cycle, and also a way for us to intervene to prevent new mood episodes.
Yeah, as a matter of fact, I often tell family members and patients, the canary in the coal mine here, the kind of first thing is change in sleep pattern that sort of heralds the onset of a mood episode one way or the other. So let's talk about that. How does the sleep disruption differ? Let's say bipolar 1, bipolar 2, mania versus depression. Well,
let's think about what is happening with the sleep cycle, right? So it's important to remember that this is the sleep process is controlled by several different factors, actually multiple different factors in the brain. We know that there are at least two main factors that control sleep. So the circadian process, as well as something that's known as the homeostatic or sleep drive. And so this suggests that sleep is under circadian control, but it's also affected by behavioral factors. So when you ask about how sleep differs across bipolar disorder, different subtypes of bipolar disorder, mania, depression, the answer to that question is that we see disruptions in sleep in all phases of the disorder, in depression and in mania, and in any subtype of bipolar disorder. But the directionality of change varies by mood state. So typically we see decreases in sleep and phase advances of the sleep cycle in folks with mania or hypomania, whereas we see hypersomnia and phase delays in individuals with bipolar depression.
Got it. So it's almost the opposite.
In some ways, like I often talk to people about, a manic or hypomanic state is, sort of a metabolic overdrive. So you're, burning through neurotransmitters, your activation levels are increased. Metabolically, you're sort of in a consumption mode, and depression is almost the inverse, where you're going into a hibernation state, and you have much less brain activation, especially in some of the centers of the brain that control things like sleep.
Yeah. Maybe for some of the newer clinicians who are listening, could you just describe phase advancement and phase latency in sleep? What does that mean? What does it look like so people can recognize it?
Yeah. So a phase delay. So we think about the circadian system as having kind of a normal, more or less 24-hour cycle. And we expect certain things to happen on a certain schedule according to the circadian clock. So let's just say like a modal circadian process would involve going to sleep around 11 o'clock at night and getting up at 7 o'clock in the morning, right? And at least a big part of that, not all of it, but a big part of it is under circadian control. When that phase is delayed, it means that you are behind the curve. So instead of falling asleep at 11, maybe you fall asleep at 1 o'clock in the morning. And instead of waking up sort of at 7 o'clock in the morning, that your body and your brain are still asleep at 7 o'clock in the morning. So you get up at 9 o'clock in the morning, right? So this is a delayed phase of sleep. The opposite can also be true. You can be phase advanced. So things can happen in advance of sort of like the modal circadian time. So you get really tired at, 9 o'clock at night, can't keep yourself awake, but then you're up at 5 o'clock in the morning and can't fall back to sleep. So you can have the phase of your sleep cycle, but also other circadian cycles as well, changed relative to sort of the modal circadian pattern.
And roughly the latter, you said the advancement is more common with depression and the delay is more mania, or do I have it backwards?
So let me back up. I think one thing to know is that people with bipolar disorder tend to be more typically phase delayed, which is to say that we also talk about morning larks and night owls. So people with bipolar disorder in general tend to be night owls. They tend to be delayed. They tend to sort of not get sleepy until later, 1 o'clock in the morning. They're the people who are, oversleeping, having trouble getting up, and, sort of do better if they can have a phase, a different phase of their, a schedule that respects their natural, we call it chronotype, their natural sort of biologic phase. In folks with bipolar, with mania, that cycle tends to be shortened. So you tend to have, you may be falling asleep late, but you're also waking up early. So your phase is foreshortened. In folks with bipolar depression, the phase delay persists often. So people have trouble falling asleep, but they really are hypersomnic throughout the day and just, sluggish, just sort of downregulated for much of the 24-hour cycle.
Yeah, I've always been fascinated that the DSM criteria for a major depressive episode is either too much or too little sleep. It's just always found that fascinating. Hypersomnia, hyposomnia, hyperphagia, hypophagia. So it's just a disruption, dysregulation, I guess is one way to say.
It is dysregulation, but I think folks with bipolar disorder tend to be more hyperphagic, hypersomnic.
That's right.
In the depressive phase, which makes sense, again, sort of like the opposite of mania in a way.
Yeah, exactly. And they tend to have more atypical depressions. I saw a statistic, and you would know better than me, about 2/3 of a bipolar's depressive episodes have atypical features. Does that sound right? Something like that.
Sounds right. I mean, in general, it's, if you're seeing an atypical depression, of course it can be unipolar depression.
Right.
But you would definitely want to at least have some suspicion of bipolarity if you're seeing consistent sort of atypical, hyperphagic, hypersomnic, depressive presentations.
And that really fits with this sort of dopamine dysregulation theory, bipolar. Dopamine's lower, you're going to sleep more, be less aroused. You're going to want to eat more to self-medicate with food and that kind of thing. It's a very, very primitive conceptualization.
Yeah. Well, sort of the reward circuits of the brain are
disrupted.
Those are all, sort of dopamine, high dopamine sensitivity brain regions.
Now, those of us who've gone through medical training and had nights on call know that sleep disruption and decreased sleep can precipitate hypomanias and manic-like symptoms. So what is the evidence of that? Sleep loss or circadian disruption can precipitate manias or depressions.
Yeah, there's some good studies showing that that getting less sleep can precipitate typically manias. There's less evidence for depressions, but certainly for manias and hypomanias. Things like studies of people traveling across multiple time zones with bipolar disorder, destabilizing and ending up, hospitalized after, transatlantic flights. There have also been studies looking at, these are retrospective studies, but looking at rhythm disrupting life events, also being associated with in the immediate period before episodes, being associated with onset of manic episodes. So, I think it's pretty clear that decreased sleep can be a direct trigger for bipolar episodes, predominantly manic episodes, hypomanic episodes. Yeah.
So people with bipolar should avoid shift work jobs or shift changes. That's going to disrupt sleep too.
Yeah. So the way, we all face circadian challenges throughout our lives, right? When we change, from summertime to wintertime to summertime, we travel across time zones. We are doing shift work. Most people's brains can reset themselves. It's not all that pleasant, right? Nobody really loves being jet lagged or post-call, right? It's pretty unpleasant. But if you don't have that biologic vulnerability to bipolar disorder, you can usually relatively quickly right the ship and get back on track. If you have bipolar disorder, your brain is much more vulnerable to those kinds of challenges, and the process of getting back on track is much harder. So oftentimes you get stuck in that jet lag-like syndrome, which actually really mimics the symptoms of bipolar disorder, right? The mixed up sleep times, mixed up appetite times, concentration issues, energy challenges, like all of those things, which are, also hallmarks of jet lag, but also hallmarks of bipolar episodes. These things get instantiated and are difficult to reverse if you have that biologic vulnerability to bipolar disorder.
Interesting. Now let's try to help our audience, our clinicians listening. What kinds of questions should clinicians be asking beyond how are you sleeping, or are you having trouble sleeping? How can we get a little more granular?
Yeah, I think walking people through their sleep patterns can be really helpful. So I usually start with, sort of saying, so what time do you go to bed? And then what time do you fall asleep, right? So there can be a disjunction between the time that somebody goes to bed and then the time that they fall asleep. So you want to look at difficulty falling asleep. And then I typically jump to, well, then what time do you get out of bed? And also what time are you waking up? Because also sometimes people, wake up at 4 o'clock in the morning but don't get up until 8. And then ask about, the sleep quality. So when you are asleep, are you sleeping well? Are you up at night? How long are you up for? So you want to get a sense of sleep duration, but also difficulty falling asleep, sleep continuity disturbances, early morning awakening, all those things that we would want to know about in terms of assessing sleep quality. And also, you can find out really interesting things. Like I was talking to someone this week who said, I'm having a lot of trouble falling asleep. I'm like, well, what time are you going to bed? They said, about 9 o'clock. I was like, okay. And what time are you falling asleep? It's terrible, doc. I don't fall asleep until, midnight at the earliest, sometimes 1. I'm like, okay, what time are you getting out of bed? They're like, typically around 10. And they're having some sleep continuity disturbance as well. But the point is, of course, if you're going to you're not going to fall asleep at 9 o'clock if you're getting up at 10 o'clock in the morning. There isn't enough. You don't have enough sleep drive, right? So that's the homeostatic component of sleep. You have to be awake for long enough in order to be tired enough to go to sleep. So really, that is not a sleep disturbance. It's they're going to bed at the wrong time. And you want to have an alignment between the time that somebody goes to bed and the time that they ought to be falling asleep.
That's a really good point, because sometimes people have certain expectations. It seems like everybody goes to bed at 9 or 10. I should do that. But maybe that doesn't work with their clock. I love how you've conceptualized this, too, about thinking about the beginning, the middle, and the end of the night, and asking about quality of sleep. And I especially like what you said. When you say to somebody, what time do you go to bed? That's not necessarily the time they fall asleep. And I think sometimes clinicians don't get that specific. Same thing with wake up versus get out of bed. So I think those are great questions. Let's talk about circadian rhythm instability. I said this in my bias. I told you that bipolar is as much circadian disruption as it is motivation, reward, and mood. But what can you tell us about circadian rhythm instability and how that relates to bipolar?
So there's been a lot of basic science looking at circadian biology and bipolar disorder. A lot of the work has been done for instance, in animal studies. So there's a really cool mouse model where the genes that and the proteins that comprise the circadian system have been pretty well described. There was a Nobel Prize for identifying those genes in fruit flies, right? In E279, I think it was. But anyhow, the mouse models that have been used to help us understand bipolar disorder include looking at mice where the clock gene, so that's one of the genes that's important in the regulation of the circadian system. They knock that gene out. It's a knockout mouse model, and those mice display behaviors that are similar to manic behaviors in humans. So they're so mice are typically nocturnal animals, but they are up during the day when they should be sleeping, and they are very reward seeking. So, sugar water, sexual behaviors. So they're very appetitive, and you can reverse that by administering lithium. And so, this is we haven't had direct evidence of these kinds of changes in humans, but I think the circadian system is evolutionarily conserved across species, and so it's highly likely that our understanding of other mammalian circadian systems can probably be generalized, at least to some extent, to humans as well. And so it seems likely that these circadian markers are dysregulated in humans as well as in animals, and contribute to the underlying instability model of bipolar disorder.
Well, that's fascinating. And of course, I'm very interested in lithium. Our friend Jonathan Meyer with Stephen Stahl wrote the Lithium Handbook 2 years ago. And there's a whole lot of interest in lithium as far as being neuroprotective and helping with neuroplasticity. But I wasn't aware of any information about this effect on circadian rhythms and other behavior. We know it's an effective treatment for the symptoms of bipolar disorder, of course. So that's really interesting.
Yeah. Okay. I mean, I think the circadian system, I think in almost all the models that we have, primary disturbances in the circadian system are, pretty well accepted as an etiologic component of bipolar disorder. Again, it's multifactorial. I mean, it's pretty clear that there's, as you pointed out, that there are other systems involved, that it's a pro-inflammatory process, that it's, there's dysregulation and lots of other systems as well. But I think that there's been enough converging evidence to, I think, say with confidence that bipolar disorder is a disorder of circadian dysregulation.
Yeah, that really fits certainly my experience. I've been thinking, I've sort of always conceptualized bipolar as dysregulation of mood, dysregulation of motivation reward. When they're manic, they're pleasure-seeking, depressed, they have anhedonia. But I have been thinking more and more, and some of this is driven, frankly, by drugs in development that hit the orexin system. And as I've been learning more about that, I realize, my gosh, this is dysregulation of arousal, circadian rhythm, and as well. And I don't know that clinicians have focused on that as much, and hopefully we'll have more tools soon to help. But speaking of tools, you are very involved with advancing a form of therapy called interpersonal and social rhythm therapy. And it's been used to improve mood stability, prevent relapse. So maybe you can just explain that, because I don't think everybody's familiar with that. How does it work, and how would a clinician access it, let's say?
Yeah, well, let me just backtrack for a second and
Sure.
talk a little bit more about the circadian system.
Yeah,
So,
please.
one of the nature is brilliant, right? So one of the really cool things about the circadian system is that it's an autonomous system. It has its own internal autonomous rhythm regulation that sort of repeats itself on a 24-hour cycle. But it's also an open system, which is to say that it can be modified by inputs from the environment. And it fundamentally allows organisms, again, this isn't just humans, to live more harmoniously with their environment, so that you're awake and alert and motorically strong at times of day when your prey is most plentiful, so that you're quiet and sleeping at times of day when you're at risk and you want to hide from predators. So it allows you to kind of be in sync with the environment. But and the environmental factors that help modify the circadian system, the most potent one is the light-dark cycle, right? And so we know that there are actually physiologic tracks from the back of the eye to the central pacemaker for the circadian system. That's called the suprachiasmatic nucleus, right? So there's direct inputs from your eyes to your brain. So when your brain is very sensitive to the rising of the sun, the setting of the sun, when it's light out, how much light you get. So that's really important. But the truth of the matter is we have circadian clocks throughout our entire body. In every tissue, there are circadian pacemakers. And so there are a whole bunch of different kinds of inputs that help to regulate our circadian system. So the GI tract, for instance, when we eat something, our bodies are sending signals up to our brain that this is like a mealtime, right? So there's a host of ways that our bodies get input up to the circadian system and can regulate it. So interpersonal and social rhythm therapy sort of leverages this idea that the circadian system is open to environmental inputs. And what we're doing in this therapy is we're working on a variety of systems that external environmental systems that help to give inputs to the brain to help tell our brains when it is, essentially to provide the scaffolding and the structures to stabilizing underlying disturbances in the circadian system. And so we're working across a variety of things that humans do during the day with the lens of using them to stabilize our circadian system. So getting back to the light-dark thing, we're going to be talking with people about their light exposure, the importance of darkness at night, which is a protective factor for the circadian system. We're going to be talking about regular meals. We're going to be talking about regular activities at specific times of the day. We constantly want to ping our brains to help it understand when we are in the 24-hour cycle.
Well, that's very logical. My goodness, that makes so much sense. And it sounds pretty practical. I mean, it sounds like something that doesn't necessarily require a whole lot of specialized training. Am I right? Is it something clinicians could implement?
So interpersonal and social rhythm therapy is actually a hybrid treatment. It consists of interpersonal psychotherapy, which is a well-described psychotherapy for unipolar depression that focuses on interpersonal relationships. So humans, most of what we do occurs in the context of relationships, so we want to contextualize it that way. So it's interpersonal and social rhythm therapy. The social rhythm therapy is this much more foundationally behavioral approach that I'm talking about. if we're going to do a whole model, we combined IPT, interpersonal therapy, with SRT, social rhythm therapy. And it can take some training to try to sort out the various components and sequence them and optimize them. But we've recently been doing a lot of work with just the social rhythm therapy part, the scheduling part, the behavioral part. And that, I think, is pretty intuitive. I actually ended up writing a workbook, which is like available on Amazon or whatever, which is patient facing, and people are using it by themselves to walk themselves through exercises that enable them to develop more regular routines and rhythms to shore up their circadian system. So, I think that there's some, that's one of several resources out there that patients can use, but also clinicians can direct their patients to without taking up a huge amount of time, especially if you're doing a med management visit.
Yeah, I'm a big fan of workbooks and patient-facing things. Now, Holly, don't be shy. Please self-promote. What is the name of this workbook and how can people get it?
It is called the Social Rhythm Workbook for Bipolar Disorders. And it's published by New Harbinger Publication, and it's available from the publisher. It's also available from Amazon. Good old Amazon.
People could just search your name. And so please, I just made this mistake offline earlier when I was talking with Holly. It's not Swartz, it's Swartz. So it's Swartz. So please search that.
But, the publisher, as I said, is New Harbinger Publications. And we intentionally made a bunch of resources available for free. So the workbook explains all these concepts of circadian rhythms and has a sequence of exercises. But it was really important to me to make sure that at least some of these resources would be available for free, especially for patients who might not want to invest in a workbook, which I totally get. And so the New Harbinger publisher has free downloadable resources on their website linked to the workbook. So yeah, sure, go out and buy it, that's fine. But also I want to make sure people know that there are free resources available as well.
Well, that's fantastic, yeah. And while you're at it, get Holly's book on bipolar II disorder. It's the state-of-the-art review. I'm sorry, I don't mean to embarrass you, but it really is. Okay, let's see.
Wait, can I plug another resource, which is also free?
Please.
So we have a free online training website for interpersonal and social rhythm therapy. So if you really want to learn the whole model, it was developed originally with funding from the National Institutes of Health, and we've continued to make it freely available. It's IPSRT.org. And there's approximately 8 hours of free training available there. So if you want to learn the whole model, that's available to anybody who's interested in learning more.
Okay, great. I'm just going to repeat that for everybody. It's IPSRT.org. I think that sounds like a great resource. Thank you. Okay. Now, when we're talking about insomnia in general, of course, the American Academy of Sleep Medicine recommends cognitive behavioral therapy first before medication. But when we're talking about a bipolar patient with insomnia, how do we decide between the different types of treatments, between, say, CBT, medication, or both?
So I think mania is a medical emergency. So if we think they're manic, I'm going to intervene with every tool at my disposal. I want to make sure they're safe, and I want to keep them out of the hospital if possible, or if they're in the hospital, to get them well as quickly as possible. And so I'm going to use medications. I'm going to use anti-manic medications, and I'm going to treat fast and whatever I need to do to help people's, stabilize. However, behavioral interventions are quite useful, adjunctive to medication for individuals with bipolar disorder who are not in an acute manic episode. I think when someone's manic, it's really hard for them to participate in any kind of organized psychotherapy, right? But I think teaching people the skills that they can use to protect themselves from rhythm disruption, and sleep-wake disruption is important, but there are also other rhythms that are really important too. And so helping people learn to regularize their rhythms, to recognize when their rhythms start to become unstable, and have a bunch of tools in their tool belt to help them reestablish regularity is really important. So do I think CBT is a good treatment for bipolar disorder? For sure. So the There have been trials of several evidence. If you look at the guidelines for psychotherapy for bipolar disorder, there are 4 evidence-based psychotherapies for bipolar disorder. There is formalized psychoeducation administered as a group or individual format, cognitive behavioral therapy specifically for bipolar disorder, a family-focused therapy, and then interpersonal and social rhythm therapy. And there have been studies of all of these treatments. They all work. And there's been no evidence that one is better than the other. So these are all great approaches to helping people with bipolar disorder. And they have all been generally tested in combination with medication.
That is extremely helpful again. And I guess you can use more than one of them at a time. Medication education goes with any of the others, for instance. So that
look,
sense.
I mean, that's the other thing. If you kind of look at like what people are actually doing in these therapies, there's a lot of overlap. So virtually all of them provide psychoeducation. Actually, there's mission creep. So because IPSRT has been so successful, virtually all of these psychotherapies also address routines, rhythms, and sleep. Well, sleep, of course, because that's part of bipolar disorder. So, there's a lot of overlap, I would say, across these evidence-based therapies.
Absolutely. Well, when we're talking about sleep medications, and I guess when you're talking about mania, of course, the most effective treatment probably is treating the mania itself. But when we're talking about sleep medications in general, are there any that you'd be particularly concerned about using in bipolar? And I guess I'll give you a quick example of what I'm thinking of. It wasn't that long ago that people were using amitriptyline for sleep, believe it or not. Well, obviously a tricyclic to me sounds pretty destabilizing if you're bipolar. But what about antihistamines and anticholinergics in general? And are there other meds we should be concerned with?
Yeah, so I think antidepressants as a class, so whether that's a tricyclic or something like trazodone, I think, have theoretical risks. Mirtazapine, these are all medications that are used for sleep. In folks with, clear bipolar 1 disorder, I probably am not going to use those medications in those individuals. I think, there's a risk of switching and mood instability. So I think that those would be medications that I would typically stay away from. Bipolar disorder is a polypharmacy disorder. So the mean number of medications that someone with bipolar disorder is treated with is 3. And so there's a real opportunity for drug-drug interaction. So you want to be careful and take a look at, anticholinergic load, antihistamines, sort of collectively, probably fine in isolation, but I think you want to also look mechanistically at, other medications that you're using to stabilize bipolar disorder so that you don't, sort of have problems with, in particular, like, for instance, an anticholinergic burden for a patient. So, there's no great sleeping pill in the world, right? I mean, we wish, but, and there's medicines that are sedating for sure, but I think if we can arm people with strong behavioral strategies, we're doing them a favor because there's no free ride with medication. Not that I'm opposed to medication. I'm not, but.
Well, I mean, people often use olanzapine or quetiapine, which you get a lot of things at once. You're treating mood, you're helping sleep, and so on. They're mood stabilizers, they're antipsychotics, all of that, antidepressants.
For sure.
So that makes sense. But
yeah, absolutely.
The reason I raise anticholinergics is more and more I've been concerned about the cognitive impairing effects of anticholinergics, also constipation and urinary retention, which can be an issue. So, if we can get away from that. But I hadn't, this is kind of naive, I hadn't thought of trazodone, but you're right, because I don't think of it as an antidepressant. It's a sleep aid,
Yeah.
But it is historically, yeah.
It is. Yeah, but the anticholinergic burden, I think there's been more work in looking at the problems with schizophrenia, right?
Yes, definitely.
And anticholinergic burden and the need for deep prescribing. But I think we can,
yes.
I think the same holds true for bipolar disorder and, the cognitive dimensions are shouldn't be underestimated.
Yeah, and mirtazapine, too, is a good point. In Europe, mirtazapine's the number 1 augmenter, actually. In America, it's bupropion, unfortunately, I guess. But back to sleep. What about benzodiazepines or the non-benzodiazepine Z drugs? I mean, benzos can be a little disinhibiting, but what do you think of that?
I mean, my opinion is that for judicious, brief use in somebody who doesn't already have another contraindication, so they're not a falls risk or they're not, a history of significant substance use disorders. I think that they can be used short-term judiciously. I think the thing that we often get ourselves into is if we start it, it's really hard to stop it. And so I feel like I don't want, again, we're talking about the sedative, hypnotic, cumulative burden over time. We don't want to leave people on these medications if we can prevent it. But I think in the short run, these can be good ways to reset the circadian clock. These are things that I often recommend that people use, to protect their sleep when they travel across time zones, if they need to reset themselves, when they've arrived in a new time zone or when they're reacclimating to their home time, so that they can use that as a tool. I think of them as tools in resetting the circadian clock and the sleep-wake cycle rather than the primary solution for that issue.
I remember a time when we were using clonazepam because Guy Chouinard in Canada, of course, had published about clonazepam and bipolar and all of that, and it was thought because it was longer acting and smoother, it was safer. I don't know, but yeah, I think I agree with you that there's probably not a role for them as long-term or foundational or anything like that.
No, I don't think there is.
Yeah. The other question then is about the DORAs, the orexin antagonists. It seems to me they might be a good choice, but what do you think?
Yeah, I don't think we have a lot of data. I mean, you would know better than I, but in bipolar disorder, I've not seen very much. I mean, theoretically, they could be good options because the side effect burden is lower. I think it's an interesting idea. I don't think that there's much data as far as I know, anyhow.
Not specific. There are data on unipolar depression, and certainly with the Z drugs. I was an investigator on a study with Zolpidem, for instance, added to SSRIs, but there's similar things. It makes sense to me more. It's a little more physiologic. You're working on the orexin system, the arousal system, and what they're doing is not knocking you out from above. They're sort of toning down the arousal system. So I don't know. It kind of makes sense to me that it would be good, but.
Yeah, I think it's interesting. The other thing is the melatonin modulators, right?
Like, thank you. Yes.
Agomelatine. Yeah. I mean, these are interesting. I mean, there have been some studies of agomelatine for bipolar depression done. I think Joe Calabrese.
Joe's done one. Yeah.
Joe did one. Yeah.
Yeah.
But
actually, melatonin itself, Holly, is interesting. Used a lot over the counter, and that makes a lot of sense to me too, especially for those people who have the phase delay, maybe. Yeah.
So melatonin is so interesting. I mean, I think. One of the things a problem that we have here in the United States is it's relatively unregulated, right? And so I mean, the circadian system in folks with bipolar disorder is quite sensitive. So I do worry about giving unregulated amounts of melatonin to folks with bipolar disorder, not knowing exactly what they're getting. If I could deliver research-grade melatonin that I know was, a purified and reliable dosing, maybe we could ping the system in a way that makes sense. I struggle a bit with the fact that, there have been a lot of studies where they've kind of opened up, capsules of melatonin and found, hanging. So I don't know. It's just, I mean, it's theoretically a good idea. I think in the United States, we have issues with lack of regulation around these over-the-counter products, though.
Yeah, there are more reliable places to get supplements, supplement stores, health food stores, and when you see the USP certified on the label, that's a little better, I guess. Yeah. And it's interesting, the side effects of too high a dose of melatonin, and it's always interesting, very individualized dosing. But if the dose is too high, what you get is vivid dreams and nightmares, and that means you got to back down if people are using melatonin. So.
Yeah, right. Melatonin's a little tricky. I mean, it's not, again, I'm happy to use any tool that's available to help people do well. If it works, great, but, just there's some caution that has to be applied, of course.
Yeah. Well, now we've talked about how changes in sleep can be sort of the early signs that trouble's brewing here. So how can restoring sleep abort a mood episode? Can it, first of all, if I kind of intervene early and aggressively?
Yeah, I mean, I think one of the things we often talk about in bipolar disorder is early warning signs. And so our goal is to identify the earliest signal that somebody is destabilizing and intervene to stop that process, right? So so we really want, this is why, using some kind of tool to monitor mood, but also sleep activation can be really useful because you can catch, ideally, these early warning signs, intervene early, and stop the process from getting out of control. So again, I think learning to recognize those like early, like, early disruptions in sleep cycles and not letting it go, doing stuff.
Yes.
Can be really helpful in aborting manic episodes. Yeah.
Yeah, this is why I teach family members, caregivers, and patients about that. Exactly. Another resource we should give out, Holly, is the Depression and Bipolar Support Alliance website. Our friend Roger McIntyre's on the board. It's dbs.org, and it's great for family members and loved ones because it has a lot of this information about what to look for, what to do, and how to help, and so on. So
100%. DBS is a phenomenal organization.
Great.
Yeah, totally support that.
I found that too. When we're talking about hypersomnia, how do we know when we got hypersomnia from the illness or just any change in sleep versus effects, medication effects, substance use effects, stressors, things like that? It's hard to tease that out sometimes.
Yeah, no, I agree. It is hard to tease it out. A lot of the medications that we use intentionally or sometimes not intentionally are quite sedating. And, ingesting other substances, of course, can affect all these things as well. I think if you work collaboratively with somebody, you can sometimes manipulate one variable. So I'm trying to think, thinking of, we learn the most from our patients, right? So I'm thinking of somebody that I've been working with recently who was on someone with bipolar disorder on quetiapine and a lot of morning sedation. We weren't clear if this was a depressive episode or medication effects. And so what we did was we changed the timing of the administration of the quetiapine. We moved it around, and it was pretty clear it was a quetiapine effect, right? So after about 12 hours, it kind of wore off. So it wasn't, so I think, if you have a good collaboration, you can do little mini experiments to try to figure out what's going on. But of course, sometimes it's hard to sort out.
No, I love that idea. The other thing is, I've always found that medication doses are not static. It's not set it and forget it. Sometimes you have to adjust the dose based on where they are in the illness, maybe a little less when they're depressed, so you're not over sedating, maybe a little more. And I don't know what you think of this, Holly, but for appropriate patients, I've actually given them permission to adjust the dose of their medication accordingly. What do you think of that? Is that risky?
Yeah, I think they're, people are, experts on themselves and, again, working collaboratively because, I think that we also have an important role to play in making these decisions. But I think, giving people permission to flex things a little bit. The other thing that I often do is give people a couple doses of a rescue medication. So if their sleep is really disrupted and they can't get a hold of me, they've got, a couple pills of something, and, it will vary from person to person what that is to just help them get their sleep back on track, which, as we've talked about, is a really important vulnerability factor.
I love that idea. I've done that too. Absolutely love that idea. And when it's the shared decision-making and empowering the patient, I think it goes better when they have a sense that there is something I can do about this. It's not inevitable, if you will.
Yeah, I agree.
The other thing we need to talk about if we're talking about medicine is the fact that there's no one-size-fits-all. And every manufacturer so far, Holly, in my experience, has gotten dosing wrong. I'm sorry. Their recommended dosing. And quetiapine's a fantastic example. The dose that was recommended was 300 milligrams for bipolar depression. And I can tell you where that came from. I don't think you were in the room for this, but Joe Calabrese and Roger McIntyre and Joe Goldberg and I were. And when they were going to do the bipolar depression, which ended up being bipolar Boulder 1, and Joe Calabrese's first author. I'm an author on. I'm Dr. et al. On that one. It's Calabrese et al. But anyway, the dose that was effective for mania was 600 milligrams. And when we had the ad board to talk about this, they said, we're going to use our bipolar dose of 600 milligrams. And you could hear the air sucked out of the room as we all went, oh, it's too high. They said, okay, we'll cut it in half, 300. It won't work. Well, it worked, of course.
Yeah, of course.
So there's no science behind that. And that's a very crude story. You'd hope there's more thought behind it. But the point is that you have to individualize the dose, and you do have to give people sometimes permission to adjust. Don't be a slave. What I say, recommended dosing is not required. What's required is use your judgment and do what you think is best for your patients.
Look, in our bipolar 2 study, so we did a study in bipolar 2 depression of IPSRT, with and without quetiapine. And in that study, the mean dose was 150 milligrams of quetiapine. And so, so we flexibly dosed, and so we weren't. This was sponsored by National Institutes of Health, so we weren't beholden to any company. But we ended up on and the Boulder studies fortunately did study bipolar 2 disorder, but bipolar 2 disorder is often neglected and may have a different physiologic response to some of these compounds. And so I agree with you wholeheartedly. I think adequate dose ranging studies are expensive and can't take into account all of the different clinical scenarios that we see. So I totally agree with you that a more flexible dosing approach is important.
Yes. Well, as one of the authorities on bipolar 2 disorder, we need to mention there's only 2 medicines FDA approved for bipolar 2 depression. You mentioned quetiapine, the other's lumateperone. Of course, that was even worse. That came out with 1 dose. That was it, 42 milligrams, 1 pill size. And I think we know that there's no one size fits all. So. But again, I don't know what you think. I kind of think of the lumateperone as more modern quetiapine with a little less weight gain risk because they both seem to play in the same spaces a little bit here. Both
look, always, again, we want to have lots of options, right? And the more the better. If we're talking about bipolar 2 disorder, we don't have enough. So having another data on another compound in that space was huge. I'm really grateful for Intracellular doing that. But now J&J. But I think more is needed for bipolar disorder in general, for bipolar 2 disorder in particular,
and for bipolar depression in particular. And just because the others aren't approved doesn't mean they don't work. They just were not studied in bipolar 2 specifically. So
100%,
we should mention that because I know clinicians who use some other things for bipolar 2 off-label and so on. So obviously you want to use FDA approved, ideally, but at least evidence-based is what I would say.
For sure, yeah.
Okay, well, boy, Holly, I can't believe how fast the time has passed. We're coming up against the end here, but I think I'd like to end with some practical advice. So if clinicians who are listening today, and by the way, I should tell you, this podcast has become popular. We have lay people listening as well, not just clinicians. But if we're focusing on clinicians, what can they do to change how they monitor or intervene in sleep with bipolar? What might be the greatest impact on preventing relapse that we could give them?
So the most important thing that people can do is get up at the same time every day. We want to ping our circadian clock and get it on track. And the most powerful way to do that is to get up at the same time every day, including the weekends. People often focus on trouble falling asleep, but really it's the time that you get up that's actually going to set your ability to fall asleep and sleep well. So one of the things that we as clinicians can do and people as individuals living with bipolar disorder, but really, as we say, anybody with a brain will benefit from regular circadian rhythms. And the thing that's going to be actually most potent is getting up at the same time every day. Probably the next most important thing to do is to get enough light during the day, get enough darkness at night so that you don't mix up your circadian system. So you want to get sun exposure during the day and turn off all of your screens because they all emit blue light at night. Yes.
So don't move to Alaska or Sweden, I guess, if you're bipolar. It might be.
Well, you can wear amber glasses.
Oh, perhaps. That's true. There's ways around it. That is really, Holly, I did not know that about the waking up at the same time every morning. So that's a very practical tip. And it also brings up those wonderful detailed questions you mentioned about querying not only what time do you go to bed, but what time do you actually fall asleep, what time do you actually wake up, and what time do you actually get out of bed. So that's extremely practical.
When I think about people getting up in the morning, I think about 3 things. You're going to be alert, you're going to be awake, but you need to be vertical because there's actually there are sensors in our vascular bed that feed back up to the suprachiasmatic nucleus about our blood pressure. So it'll actually be able to tell us that we're vertical as opposed to horizontal. So you need to wake up, you need to be vertical, you need to get some sun, go near a window if you're not going outside, and eat something because you want your GI tract to say, okay, it's morning. So you really want to send as many inputs to your brain as possible to help regularize the circadian system.
So even eating matters. We didn't talk much about that, but that's fascinating. I hadn't thought of that.
Yeah, lots of things that we can do.
I know.
It's a rich area for people to intervene.
Yeah, and of course we didn't talk about what to eat, diet, and those effects. Of course, we didn't talk about alcohol and marijuana, which people sometimes use. But how about this? Maybe we'll do another podcast on those things, Holly, because I really I enjoyed talking to you. I learn from you always. So
likewise,
thank you very much.
It's been a pleasure.
Yes. Well, thank you, all the audience, for listening. And for more information about NEI and our products and services and live meetings, you can go to our website, which is neiglobal.com. And for more of our podcasts, which we've now been doing since 2019, anywhere you get podcasts, you just search for the NEI podcast or me, Cutler. I'm indexed as the host. And thank you for listening, and good luck with your clinical work.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.